Welcome everybody. More Good Days acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past, present and emerging, and we extend that respect to all Aboriginal and Torres Strait Islander peoples today. Welcome everyone, I'm Sonia, I'm one of the support coaches here at More Good Days. For anyone who is new, we've had quite a few new people recently, so I am one of the support coaches. I have fibromyalgia. That's my particular spicy soup of chronic pain. And I've done the More Good Days program and had some really good results with it. Before I go any further, I'd just like to remind anyone who's attending live that your presence today indicates that you accept the rules that were invitation. And that is no hate speech of any type will be tolerated. Please keep your microphone muted and wait to the end for questions or type them in the chat. The chat function is down in your bottom right corner of your screen. It's a little text bubble and you can type your questions in there. We do have a lot to get through today. We'll do our best to answer any questions that are asked live, but we may not have time to get to them. Today I'm joined by Dr. Stephen Liu. Stephen is a specialist general practitioner who has worked closely with us here at More Good Days for several years. He is a trained provider in focused psychological strategies and holds a special interest in mental health and chronic pain management. Stephen believes that a whole person, continuous, patient-centered care can be better delivered through innovative models, including technology. Today's session, we're going to be discussing a few different types of pain management medications, what they are, how they work, and what you need to look out for. We'll be talking about the purpose, dosage, side effects and effectiveness of specifically Amitriptyline, low-dose Naltrexone, Ketamine infusions and medical cannabis, and how medications fit into an overall pain management approach. Here at More Good Days, we do believe that medication has its place as part of an overall pain management strategy, but our program focuses on a biopsychosocial and multidisciplinary pain management strategy. We do not recommend or prescribe any specific medications, but we get a lot of questions about medications. So we did ask Dr. Stephen to join us and help address some of those questions. Dr. Stephen will not be able to talk about specific conditions and drugs in too much detail, as that's always really individual. He won't be able to answer specific questions about your dose, your medication, and all of those kinds of things. That requires a really thorough history taking and understanding of what's going on, and it's best addressed as a one-on-one setting. So with all that out of the way, I'm really pleased to welcome Dr. Stephen. Thank you so much for joining us today.
No, thanks for having me. This is a super meaningful topic. Naturally, I've seen a lot of this, and I've personally probably seen hundreds of thousands, not hundreds of thousands, but hundreds to thousands of patients who have had various types of chronic pain, including fibromyalgia, but of course things like chronic back pain, including things like also post-injury pain, complex regional pain syndrome, etc. And I think this is a super important topic because I think medication absolutely does have a role in helping, but these are often it can be used probably in the not the most favorable or the most sort of like beneficial way, and I've seen that a lot in my career and with the work that we've done together, Sonia, right? So like a lot of the patients that we've seen through More Good Days, you've probably heard me talk about it, which is often often I end up spending more time de-prescribing folks to say, hey, look, some medication might not be the best for you, and are they doing more to help than they are to hinder? So just to be able to share some more clarity in terms of how, like you said, we're not here to do one-on-one consults today, and yes, it needs to be incredibly personalized in terms of individual causes of pain and life context and other externalities like mental health and social setting context. But medications can be very useful, right? But they're a tool. They're a tool in our toolbox, and we want to make sure that you don't just have one tool to solve a very complicated project.
Absolutely, we don't want to use a hammer to screw in a screw.
That's right. Yeah.
Let's sort of jump into things and get started. What new treatments are currently available or in development for chronic pain management?
Great question. So sometimes there's a lot of focus on what are the new drugs and what are the new procedures and what are the new devices, but we're increasingly it's become increasingly clear. I think a lot of us who work in the industry have known this for a very long time, but it's been increasingly clear, and I think people are getting to know this, which is the best approach to chronic pain. The newest treatments is actually being able to approach these problems in a much more, like you said, biopsychosocial approach, which is looking at someone's pain beyond their pain, looking at what drives their pain as an individual. And it's this combination platter of treatments tailored to the individual that actually delivers the best outcomes. So, medication definitely has a role in this combo platter solution, so to speak. And there's a lot of strategy and nuance and tactics that need to go into that. And I think that's probably the most effective treatment. Of course, there are new treatments like, people hear about medications and people hear about, like I said, maybe there's a new procedure, or maybe there's, like nerve denervation, or maybe there's like implantable devices. And the reality is, just because that's available, it doesn't necessarily, and new, it doesn't necessarily mean it's right for you. But I think any pain provider should be aware of all these new treatments. But fundamentally, I think the newest treatment is to reapproach chronic pain through a different lens with all of the tools that we have, and trying to solve each individual person's problem. It's like solving a puzzle, and you can't solve the puzzle with just one tool, and even the sequence of actions is a little bit different for everyone. And I think that's probably the biggest, breakthrough. But I think there's more and more attention on that, and the evidence for that is incredible.
Wonderful, thank you. But yes, today is primarily about medications. So let's start with amitriptyline. It's something we hear a bit about. Can you tell us, is it for all chronic pain conditions, or is it only specific conditions? Are there any risks, side effects, things that we need to know about?
Yeah, so look, amitriptyline is a medication that I prescribe a lot. Just a little bit of history. It is technically, if you look at the box, it is technically an antidepressant, but the reality is we haven't used it really as an antidepressant for decades. It's now like third or probably fourth line for depression. But over the past decades, we've discovered its role and effect in things like chronic pain, fibromyalgia, IBS, including sometimes like chronic fatigue, and a variety of other sort of experiences. And it's particularly good because it belongs to a class of medication called tricyclic antidepressants. I always preface this to my patients and say, yes, antidepressants in the name, we don't really use it as an antidepressant. So what it does is it blocks neurotransmitters like serotonin and norepinephrine from being taken back into the nerves. So basically, it manages your neurotransmitters, and the result it delivers is it reduces the excitability, so to speak. Right? It reduces the excitability of your nerves, whether that's in your brain where you feel pain, or whether that's in your nerves where you feel pain, and whether that's in your gut where you feel, where overexcitement of your nerves can cause symptoms. And in chronic pain, often it's the pain pathway and signals that are, for lack of a better word, like overexcited. And that's why I think amitriptyline is a very, very good medication for that. It is not, if you stub your toe, that's somatic pain. That's not just for amitriptyline. We're here to mainly talk about like chronic pain. And the dose makes the poison, basically, right? So like, some people have, a lot of patients who I've seen through More Good Days, through my private practice, have used amitriptyline before, and they say, oh, actually, no, I don't want to use that because I tried it 5 years ago, 10 years ago, and I really didn't have a good effect. Often that's a dosing issue. And the way that I normally use it, chronic pain needs to be treated with clear expectations to say, we're not going to get your pain gone in 3 days' time, but we need to have a strategy to move forward on that to achieve like, incremental benefits, and try to sort of strategic and be tactical and take incremental steps. And the way that I would prescribe amitriptyline is use a very, very small dose coupled with the other things that can make it work even better, such as like psychological input, psychoeducation, more supports, physical therapy, and variety of things. So I would normally start very low dose at like 5 milligrams, which is actually half of the smallest preparation. The maximum dose is like 150 milligrams a day. I normally start at 5 and then move on to 10. Risk of side effects wise, At lower doses, it's really very, very well tolerated. You need to check with your doctor to make sure it doesn't interact with any other medications, which typically doesn't. The most common side effects that I hear about is like having a bit of a dry mouth. That usually comes on after about like probably 20, 25 milligrams per day. And also some people feel a bit like hot. Some people feel a bit quote unquote like out of it. But that's not necessarily a bug. Sometimes that's a feature for some people who are like particularly anxious. And overall, I think very, very well tolerated. So
sometimes that's an effect of having fibromyalgia in itself.
Absolutely. Yep.
That's wonderful. Thank you so much for that. So low dose naltrexone, we're hearing a lot more about this. Can you explain how it works and how it's different from the drug that's used in drug rehabilitation and alcohol dependencies? Is it for all, again, is it for all chronic pain conditions or more specific ones? Are there risks, side effects, things we need to know about?
Yeah, so I mean, dose makes the poison, right? So like, you know, the LDN, low dose naltrexone, the low dose is just how much dose we use, right? Naltrexone itself as a drug, most people have probably heard about it in the context of it being a basically to treat narcosis, right? If you've accidentally overdosed on sort of morphine or something like that, naltrexone actually can basically reverse that at the receptor level. And you know, some people might have seen on TV, or someone's had a heroin overdose, so we give them something, they suddenly wake up. That's naltrexone. So we used to give it in hospital. Ambos give it, but this drug is actually quite straightforward, which is it competitively binds to the receptors that basically, you know, like morphine and opiates bind to. But over time, we've realized that using a very low dose can do a variety of things. So like you use a big dose to reverse an acute problem like narcotic overdose, but smaller doses can be used in, like you said, like, you know, drug rehabilitation, alcohol rehab. And then in the realm of chronic pain, a lot of these came from observations to say, actually, we've used it in this case, but it's also helped this person who also has a bit of chronic pain. And over the past about 4 or 5 years, it's really gone through a lot more, taken a lot of attention, and there's more clinical studies. And the studies so far have really demonstrated that it can be a very useful adjunct tool. So in my practice, very rarely do we see LDN used as a singular medication. But then again, in chronic pain, I don't think there is one single medication that's going to help, right? So that's kind of how it works. We in the context of like chronic pain, low dose naltrexone usually taken at 1.5 milligrams up to 9 milligrams a day, but usually I'd probably stop at 4.5. If it's not working at 4.5 milligrams, I typically don't push the dose any further. But you know, like that's really a very personalized decision in terms of your personal treatment strategy, in terms of what you and your doctor decide is worthwhile experimenting with. It is a very safe medication. You do not get hooked on it. The side effects are also really quite. There's not a lot of side effects, basically. Sometimes you can get some like stomach upset. And, you know, I've prescribed a lot of LDN. Very few people actually tell me, actually I got stomach problems. And usually, like I said, I usually prescribe anywhere between 0.5 milligrams a day to 4.5 milligrams a day. The common side effect, and again, I don't know if this is a side effect, so the common effect, like unintentional effect, is sometimes people get vivid dreams. So it's not necessarily nightmares, but they get very vivid dreams. So I've had patients say, "Oh, this is like quite interesting, right?" But I think like not very commonly, but some folks I put on, they say, "Oh, actually, I don't like the dreams," and it's actually quite an easy solution. You can take it in the morning instead. So sometimes of course the dosing and the timing of administration during the day can make a difference. Personally, anecdotally, I don't think this is like well established well documented in literature, but in my personal experience, and like I said, I've prescribed this a lot, I find that like low dose naltrexone works quite well with amitriptyline. And there's almost like an offsetting effect, which means like you can keep people on very low doses of each instead of increasing the dose of one to deliver that benefit. And I think it's always good to have multiple things working for a complex problem.
Yeah, absolutely. Anecdotally, I can definitely attest to the vivid dreams. They were very interesting to start with. They wear off for me, at least. They wore off,
Yeah.
but yeah, they were certainly interesting.
Yeah, like a free movie every night, right? So that's nice.
I'm not sure my husband was impressed, but you know. We did have a question submitted in advance, and while we can't address specifically their dose, there was something quite interesting in their question that I wanted you to address, if you could. They're currently titrating their LDN dose, but they're also on Tramadol and medical cannabis. Could you have a little chat about the interactions of those drugs, please?
Yeah, sure. So to start with, the medicinal cannabis, I don't think really affects your LDN dose very much. They work in different receptors and different pathways. Medicinal cannabis, obviously, you know, also need to think about like what type, what dose as well. So broadly speaking, you know, so I'm a you know, registered medicinal cannabis prescriber as well in Australia. And I'll be honest, look, I think the benefits of medicinal cannabis has not been as overwhelming as people who do the ads, to be honest, right? So I think there is a good role for it, but again, it needs to be targeted in terms of what your strategy is, like what your specific strategy, what symptoms you want to alleviate, and also what else we've tried. So as a prescriber of medicinal cannabis, I've not really been that impressed with its benefits. Broadly speaking, you also need to think about, like, you know, are you on CBD? Are you on THC? Are you on a combo? And if you're on a combo, what dose and what ratio? And of course, you know, you also need to think about, like, different states have different regulations around the THC component of the medicinal cannabis that can affect your driving. So it's not really, might not affect your pain, but it could affect your life, right? So if you get in trouble with the police or you can't drive, so that can really limit your life. And when you have life limitations, that's not good for your chronic pain either, because you know, it limits your social interaction. So there's a lot of like downwind effects that we need to think about with medication balance. Now, on the Tramadol works in different ways as well. Tramadol is like a sort of pretty tricky drug. It works a little bit like a non-steroidal anti-inflammatory. It works a little bit like an opiate, and it works a little bit like, you know, to be honest, there are overlaps between that and like the effects of amitriptyline too. So Tramadol, like I said, you know, it works well for some people, but it is a sort of mixed basket effect kind of medication. The LDN and the Tramadol can sometimes have a bit of a competing effect. So like I said, you know, the naltrexone aspect of it, like we mentioned, is a opiate blocker, basically. It's a competitive agonist competitive antagonist for opiate receptors, and Tramadol has that effect. So it may mean it shouldn't cause extra side effects, but it may mean that you're taking two things where they, like, some of the effects cancel each other out.
Both might not be working as well.
Yeah, that's right. So it might cancel each other out, and then it's a return on investment type of like question to say, like, you know, I'm buying these medications, but like neither of them are working completely in the way that, you know, it can. So there is a bit of like a balancing act there. But having said that, though, I find that folks with chronic pain, you know, there's no rule book, right? There's no you must do this and you must not do that. I think really focusing on your outcomes. So I'm sure there are patients out there. I'm on LDN, I'm on Tramadol. I know how it works, but it works for me, right? In which case, as long as there's no, you know, significant adverse effects, fantastic, right? If it works, I think ultimately we want things to work, and a lot of times, you know, these medications are not. Some of them are very, very safe to take lifelong and long term, but you know, your chronic pain and your life are both evolving things over time. So the way that I usually do it is, hey, we found something that works, fantastic. Let's use this as maybe a circuit breaker, maybe a period of like of relief, right? And let's use that to get wins elsewhere, right? So for instance, you know, using some medication to give yourself a window where you can improve your appetite, improve your mental health, and sleep a bit better, and then do some physical activity. And a lot of those things will lift, you know, will really float the whole boat. But then having a mechanism to come back and like routinely, and that's why doctors prescribe drugs that, you know, limited scripts, right? To say that, it's not to be difficult. It's actually to say, hey, let's use the medication supply to create a mechanism where we can review you. So like it might be 1 month, might be 3 months, might be 6 months. But let's create a mechanism where we can actually review and say, hey, how are you doing? Are you improving? Is it working? And if it is, how can we make it work better? And even say, hey, if your life's going well and if your chronic pain's improving, can we reduce that dose? And see, like, so there is a bit of iteration and experimentation there.
Absolutely. Thank you. I hope that answers the person's question. I don't think they have made it live, but if they're watching the recording, hopefully that answers the question for them. I guess you did talk a little bit about medical cannabis. So let's talk a little bit more about that. You said you're a registered prescriber. Obviously you can only talk about how to get it in Australia, but could you talk a little bit about how that goes, what the rules are around driving, all of those kinds of things?
Yeah, it's a little bit tricky. I think there's some change in legislation also coming to make the CBD component of cannabis a bit more accessible, and I think that's very, very safe. It really works more like just what's called anxiolytic, so it can reduce a bit of exercise, reduce your stress somewhat. Again, I don't think it's particularly potent, and I think it's a great option for people who do not tolerate first or second line treatments. So some people might try some SSRI type antidepressants, or try some NDEP, like Amitriptyline NDEP, or try some nortriptyline, which are tricyclics, and even try some other medications like Pregabalin. Even though I try, I think every medication has its role for in the right setting, getting the dosing right. Some people had like quite sensitive to those medications, and then those ones where if we use it as a second or third line treatment, I think sometimes basically beggars can't be choosers, right? So when our hands are tied, we want to make sure that we consider all of the options. I think it's a reasonably costly option because I think if we get your medication strategy right, often these medications are on PBS. Often they're very, very cheap. So like I think amitriptyline, a box of 50 or 10 milligrams, if you take 5 milligrams a day, that's 100 tablets. I think that's like $5.60 or something, right? Whereas, often folks who have chronic pain, the chronic pain limits their lives in a way that also limits their, ability to have like financial stability and have the resources to then invest in these things. So I think we should be conscious of that and of the benefits. Like what is the return on investment of quite costly things? Because sometimes like more expensive is not better. You just have to find the right thing. Like might be 5 cents, might be $20, but we should go through this process of finding what's right for you. And if it's a $20 thing, that's totally fine as well. CBD it usually comes in oil form. So I think overseas you can get like gummies and things like that. In Australia, it's predominantly oil form. And we will calculate the doses in drops to say, 3 drops in the morning, 3 drops at night. And CBD is really quite safe. And the main effect will be, I think it helps me with relaxing and sleep. And guess what? That also helps with your pain. Now, for direct, I think analgesic effects, for direct pain killing effects, you do have to have the psychoactive aspect of it, which is the THC. So effectively, it's a THC that gets you quote unquote high. Again, I'm very open to people like experimenting, but I think the safest thing to do is actually make sure that your doctor thinks of all the options and thinks about your circumstance before prescribing. And lastly, like you mentioned, Sonia, the regulatory aspect is different states have different rules, but most states would have some THC restrictions in terms of driving, actually, which we spoke about earlier.
Yeah, absolutely. Last thing you want to do is get your pain under control and then get a fine from the police because you've driven somewhere.
Yeah, exactly.
So the next one we wanted to talk about was ketamine infusions. It's been a bit of a buzz in a few of the chronic pain communities. What's involved with that? Is it effective? What are the risks and side effects?
Sure. Okay. So ketamine infusions have been around for a very long time. Ketamine is actually, we use ketamine for anesthetics. So when I used to work in hospital in the anesthetic pain team, we used to do ketamine infusions. We would admit people to hospital, and give them ketamine infusions for their chronic pain. But the main benefit, the main evidence-based benefit, is if you are effectively, dependent, right? So you're like dependent on opiates. So you're on very big doses of, OxyContin, MS-Contin, fentanyl. But your body actually gets used to it. So over time, you actually lose its effect. You're on a whole bunch of medications, you get a whole bunch of side effects, and you're sort of stuck. Ketamine infusions is very useful in that setting for us to rapidly readjust your body. It's almost like pain receptor rehab in a way. But it is not in America, it's become quite like popular. I think a lot of people go to a ketamine clinic and they do all these things. It's they've commercialized it a bit in a way that I think under describes its risk, because it can definitely cause sort of side effects, particularly psychological side effects. So it can trigger psychosis, especially if you have a family history of, say, bipolar, schizophrenia. But guess what? THC can actually do that too. So we have to like use these things quite carefully. Ketamine is also a street drug. I think being very, very careful about thinking about ketamine, because I know that like a lot of my patients who have chronic pain, you probably relate to this yourself, Sonia, which is the desperation that comes with like finding solutions and the desperation of finding like a silver bullet solution. Ketamine is not the safest medication. It can have quite a lot of side effects, can suppress your breathing, can cause like vivid dreams and beyond, right? So it's not like LDN causing vivid dreams, but it can definitely cause, it can potentially trigger psychotic episodes if you have a predisposition to that. Like if you've had, like I said, like a mood disorder in the past. So I think risk and side effects, it's a very specialized setting type of drug. I know that a lot of pain specialists do use it, but selection is, case selection is key. I mean, it's definitely not it's definitely, I think the therapeutic range for ketamine in the realm of chronic pain is quite limited, unless if it's used in solving a very, very difficult case of like someone's dependent on opiates. I used to see people who are on like equivalent of 150 milligrams of morphine twice a day. And the ketamine infusion can really, really help, but resetting neurotransmitters is only like one small part of addressing strategically someone's chronic pain, because it's not just, hey, the goal is to get you off the short-term goal is to get you off all your super high dose opiates and morphine. But what's the long-term goal here, right? How do we sustain that? How do we, improve that? And that really comes back to the biopsychosocial, psychoeducation, understanding your pain, empowerment, having agency in your own life, and being able to speak to your own pain, and all of those things are probably the more valuable things for long-term outcome.
Absolutely. I guess the next question is, are there any new medications that are showing promise in pain management?
There's always something, and it's some things that are a bit in vogue sometimes, and others. A few years back, I think, particularly with like chronic back pain, nerve stimulation. So these aren't drugs, but like nerve stimulation and denervation. So they're and pain stimulators. I think they're all very difficult to access, very, very expensive treatments, and I think they have roles for specific cases, but they're really not. I think they're really not for everyone. So it has to be used as super case specific. I think there's always some new things, like there's what is it, cyclobenzaprine? I think
yes, there was a question about that, so I'm glad you mentioned it.
Yeah, I don't think there's ever going to be like here's a silver bullet for your chronic pain. Wouldn't
it be nice?
Yeah, wouldn't that be nice, right? Like, and whoever comes up with that, will be have a $100 billion business, I think. But that's also not how humans work. right? It's like oh, it's like your life and your family and your relationships, and nothing is gonna fix something complex very simply. Doesn't mean we can't improve it. It just means that we have to figure out like what fixes what in what time frame. I don't know about cyclobenzaprine. As I think they're going to fast track. I think it's mainly used for like they experimented with its use in fibromyalgia. I think it might be useful, but I don't think it's gonna. I don't think the drug itself is going to change people's lives. It's usually like programs.
Yeah.
It's usually programs that addresses all these things.
Yeah, like ours.
Yeah, that's right. Yeah, like
the question that was about cyclobenzene, what was about fast tracking, and whether I suppose could you talk a little bit about, and this is the FDA, which is America, but ours is the TGA. What do we have any concerns about when a drug is fast tracked through one of those regulatory systems?
I think the TGA and FDA, I think they're all quite sensible agencies, but remember they are very broad stroke in terms of how they make decisions and how they work. They're not here to say we're fast tracking this for you, right? And we think you'll benefit from it. I think they mainly look at it from a safety profile, probably more than an effectiveness profile. Obviously, it's a balance of those two things. It's a little bit like the medicinal cannabis. Like you could replace cyclobenzaprine with like insert drug name here, and then there'll always be something right in the next 2 years or 3 years, and this is the next big thing. And but this particular for chronic pain, I think I'm hopeful that there'll be something that comes out, very little side effects, delivers really good outcomes. But we actually understand this pretty well. We actually understand chronic pain reasonably well, and we know that medications alone is actually not going to solve the problem. They can be very, very useful tools, right? So just like you said, you can if you want to hammer a nail, use a hammer. But if all you have is a hammer, you're not going to build a house, right? So you need all sorts of tools. You need to work out what exactly is your goal. And cyclobenzaprine and other newer drugs are probably just extra tools in the toolbox, right? Might be more effective than some of the medications. But like I said, in my experience, in chronic pain, medications usually don't have. I think they absolutely have a role, but the role is almost never too big.
I suppose if we had a drug that had zero side effects, it probably wouldn't have a lot of effects.
Yeah. Well, I mean, a lot of my patients actually experiment with like various other things, right? So like like dietary changes, like maybe find the right diet that works for you and for your pain. Sometimes take some supplements, and which as long as they're high quality, I think they're reasonably safe. But that's also another pitfall for some, where they're always trying to find a solution that we can buy, right? And sadly, chronic pain is one of those things where if you had $1 million to spend on it, I don't think there's enough products to solve it. You can buy access, you can buy services, but ultimately, it's like getting strong at the gym. Like you can pay as much money to the gym as you like. You still need to be the one to work out, right? You can get the right guidance, you can get the right support, you can get the right motivation, you can get the right program. At the end of the day, you have to do the working out yourself. And like a service like More Good Days is really to coordinate that so you can get the best outcome that you can as quickly as you can, and also like clearing any blockers of success. I think that's one of the big things that medication can't do.
Yeah, that's fair. The last question that we had submitted in advance, we've sort of answered most of them as we went through, was about Pregabalin. You mentioned that briefly earlier. The question is specifically, is it dangerous? And I think I know what you're going to say. Is there an increased risk of overdoses, and are there contraindications with other medications?
So Pregabalin, when it came out, it was like basically marketed as a wonder drug, and I've been around long enough to know there are no wonder drugs. there was a very, very successful marketing campaign to doctors, right? At the time, it was called Lyrica, right? So, it's a nice name, went around, they really promoted the drug very, very heavily. So it went into the ethos very quickly. But like I said, every drug has its benefits. I think pregabalin is particularly good for nerve pain and peripheral neuropathies. By the way, like amitriptyline is actually quite good for that as well. So when you're experimenting, I always try to experiment with something that probably is a bit more cost effective, right? To say, if we're experimenting with both, they both seem to work, let's try the cheaper one first, and let's try the one with fewer side effects first. So again, at lower doses, I think it's totally fine. The thing that I see is sometimes people get, sometimes people end up on much higher doses, and yes, it can interact with your, other medications. But that's not the biggest problem. The biggest problem is when people are on higher doses, they tend to get, like, for instance, in the context of like fibromyalgia, right? So when we try to treat pain, and your doctor might feel like they don't have any other great options, then we increase your dose. So the trade-off of reducing your pain by another 10 to 15% might be significant weight gain. One of the side effects might be brain fog, right? And people think, oh, the brain fog is my fibro. Well, guess what else causes brain fog? Like being on a lot of psychotropics, right? So I think I'm sleeping better. Well, no, actually you're sort of semi being sedated. So it's not necessarily sleeping well. So it is very much a balance. Absolutely, high doses might work for some. But I don't think it's a bad drug. I think it's just a drug that was probably a little bit overused and overprescribed in terms of dosing as well. And this is not an invitation for anyone to go home and stop taking their pregabalin, but have a chat with your doctor and say, like, what is this drug doing for me? What are any of my drugs doing for me? And what's the strategy and what's the outcome here for me? Because here are my symptoms, right? And there's sometimes almost a complete overlap, right, with the symptoms that you might get from your chronic pain syndrome with the side effects of the medication, in which case, like, how do we work it out? Like, I can't just look at your profile and work it out. No, like, doesn't matter how much experience you have. Like, no one can know for sure because you're an individual that's unique. The only way you can tell is come up with a confident approach to iterate and say, all right, like, let's experiment a little bit. Maybe if I drop this dose, I'll feel better. But like, if I get these other symptoms, like, how do we then manage the balance of my symptoms in the context of, like, my life and my set of medications and my condition and, and timing, like during a flare, of course, like, you might need a different set of medications and different set of tools to manage it.
Wonderful. Yeah. Thank you very much for all of that, Stephen. We've covered an awful lot of ground today. And one of the things that is in the library section of our app is a mini program, which I believe Stephen helped us create, called Navigating Medications for Chronic Pain. There's also one called Advocating for Yourself in Appointments. So as Dr. Stephen just said, if you want to discuss your medications with your GP, but you're finding it difficult to have that conversation, that module is available in our library, and you can do that and set yourself up well to have this conversation in a confident way. And remember that you can choose another doctor if your doctor isn't listening to you, if it doesn't have as wonderful bedside manner as Dr. Stephen does. Then you can find another GP. It's not something, you don't have to keep going to the same one. And so find someone who will listen to you. We wish we could clone Dr. Stephen and send him out to quite a few clinics, because we do know how wonderful he is. And I guess on that note is, are you taking on any new patients in your private practice?
Oh gosh, so not at the moment, unfortunately. But I mean, that's the whole mission of More Good Days, right? Which is we don't think good outcomes in chronic pain should be limited to people who have access.
Absolutely.
It's a very, very complicated problem that really stops people from thriving and takes a lot away from your life experiences, whether if it's work, relationships, enjoyment, travel, like aspiration, self-actualization. And like I mentioned earlier, I don't even think it's a cost thing, right? So, for a lot of people, even had $1 million, I've seen a lot of people spend a lot of money and get the wrong type of care, right? So, and in that context, right, like the mission of More Good Days is not just to give you the right information, give you the right education. It's also a lot about empowerment and agency. And I think it actually starts with that. So, if you go to your doctor, like have a read of the article, how do you advocate for yourself? Because at the end of the day, you're the one experiencing chronic pain. Your life is the one that's actually being limited by this problem. The incentive for you to solve this is the highest, right? And all the doctors and the interventionalists and, external services, including More Good Days, we're here to support, but you have to captain your own ship and you have to make some decisions. We're all like, there's a lot of specialists that can give you like specific input and advice. And having agency, I think, is really important to feel like, even though you have chronic pain, you're in control of your life. And even if you go to the doctor, one thing that I would recommend people ask is say, hey, here's the dose that you've prescribed me. Under what circumstances and how can I move my own doses? Because, like I'll go home and maybe my pain will be better in 3 weeks. Or what do I do then? Or if I have a flare up, what do I do then? And, this is a dynamic thing. So I think ideally ask your doctor to give you some safety parameters and say, all right, like, so for instance, with my patient, I say, all right, let's start at 5 milligrams, but, I don't dictate your dose. I'm here to provide you with some guardrails to say, all right, if things are going this way, then you can move your own dose a little bit. So you can go up by 5 milligrams a week and see how you go. And I think that agency is really important. It's not just about the medication, not just about the dosing, but just to feel like you can actually pull the levers yourself and you can actually control these things. You're not just the recipient of a fixed dose because that's what the doctor prescribed. I think having those conversations is really important. And again, like I think we covered that in our resource, Sonia. What sort of conversations? How do you get the most out of your doctor appointment? Yeah, and look, we have fantastic doctors in this country. They all want to do well, but there are certain circumstances that make their jobs very difficult. So, how can you solve such a complex problem in 15-minute appointments or increments, right? So that's why, like, I think the More Good Days program is so great. You can do it in the comfort of your own house. You can, the content is beautifully written, and I think it's very, very clear. And just to build up that knowledge, build up that agency, feel like you're in a bit more control. And then there's strategic and tactical things to say, all right, before I go to the doctor, I want to know what questions I want to ask about my medication. I'm going to write them down and say, look, here's my list of questions. Here's what we can talk about today. We've got X amount of time in our consult. These are I want to get a bit of clarity in terms of like what I'm on. So questions like, very simple one, do you think this medication is helping more than it's hindering me in my life? And then they should say, all right, well, like, what's happening in your life? Well, my pain's not so bad, but like my brain fog is really making it very hard for me to like work and concentrate and do all this stuff. And I'm putting on weight and that hurts my self-esteem. It makes me feel bad. I'm tired. And okay, well, then maybe not, right? So like have a think about your life context, and the doctor's job is to gather that information and have a think about it and give you the right advice. And in an environment where we acknowledge that we don't have all the right answers, but we should have a common goal, and then we sort of like inch towards that. And like with all the research that we've done for More Good Days that we've put into the program, we want to make that as efficient as possible. So lots of different keys to open different locks, but
absolutely,
but that's probably my advice.
Wonderful, thank you. So anybody who has joined us live or is watching the recording, this is what More Good Days is all about, is about getting the science from multiple different disciplines, neuroscience, psychology, physiotherapy, and we try to make it accessible. If you're just starting out, remember that you can email us if you've got questions for your coach, if you're just on a self-guided version. We do have more in-depth support versions. We've got support coaches, psychologists, physiotherapists, people who can help you on your journey. But as Dr. Stephen said, the idea is to give you back the power yourself. And really learn to manage your own chronic pain, whether that's back pain, musculoskeletal pain, or fibromyalgia pain. It's to help you really get control back of your life. We're not going to promise that we're going to get you to pain-free. We wish we could, but better management of your condition is ultimately the goal. And as I said at the start, I did the program myself for my fibromyalgia. I'm an absolute shining example of how well it can work. Getting back to work, exercising, socializing, doing all of the things that I wasn't able to do prior to that made a massive difference too. And I've got control of what I can do. I've got the power to manage my own condition, which is incredibly empowering. I'm using the word power a little bit too much, but it is something that if you're just at the start of your journey, good luck. Feel free to reach out. If you're sort of already worked your way through the foundation program, check out the library, and feel free to repeat it. It's something that repeating the content is something that is usually very beneficial. Doing anything more than once, it's a skill, and like any skill, the more you repeat it, the more you practice it, the better you get at it. And overall, we'll better manage your pain and other symptoms over time. We're right at time. Thank you so much for joining us, Dr. Stephen. That was really, really helpful. Hopefully we'll have you on again in the new year. And thank you to everyone who attended live and watching the recording at home.
Thanks, everyone. Bye-bye.
Bye.